Yeah, you should be able to begin your intro.
Okay, great. Hello, everyone. Welcome to our Victoria South Island Long-Term Care Initiative Learning Series event on dementia. Please feel free to introduce yourself in the chat. My name is Jillian Swinburnson. I am the program manager for the Victoria South Island Long-Term Care Initiative, and I would like to take a moment to welcome you here. It is with great respect and appreciation that I am speaking to you from the traditional and ancestral territories of the Tsuut'ina Nation, where I am very lucky to work and live. Just a couple of housekeeping items. Please keep yourself muted as background noise can amplify very quickly. If you have questions throughout the evening, please unmute yourself and ask away. We like these events to be as interactive as possible. There are CME credits available for this event. A member of the LTCI team will email you a certificate next week for your records. At the end of the evening, we will have an evaluation. Please take a few moments to participate as your feedback is important. This event will be recorded and posted on our website. Finally, I'd like to introduce our presenter for this evening. Please welcome Dr. Jane Saunders. Dr. Saunders is a geriatric psychiatrist working in Victoria and Duncan. She is the medical lead for tertiary mental health services for Island Health and the medical director of the Cowichan Lodge Tertiary Mental Health Unit in Duncan. She has a PhD in neuropsychiatry and a master's in psychopharmacology. All right, I'm handing over to you, Dr. Saunders.
Hi, can you hear me? Is that clear?
Yep, you sound great.
Great. Well, good evening, everybody. My name's Jane Saunders, and some of you may know me and know that this is an area of great interest for me. I'm particularly interested in non-pharmacological strategies to treat folks who have behavioral complications of dementia. Next slide. I don't have any disclosures. Next. So in terms of the learning objectives today, I'm hoping that this talk we have this evening helps to contribute to your knowledge of some of the common behavioral complications of dementia with a focus on resistance to care and depression. And I've chosen resistance to care as a particular focus because I know in long-term care it is one of the most challenging situations that you face. And then also to develop the knowledge of some of the evaluation tools and strategies we can use for treating these complications. Next slide. There we go. Sorry, I seem to have repeated that. Right, so we're going to start with a clinical scenario, which is a very common clinical scenario. And that is Mrs. M, who's an 88-year-old woman who's come into long-term care because she needs 24-hour care. And she is hitting and biting during personal care. And to the extent that the staff are saying that care is actually sometimes not possible, staff are getting hurt, and she is being termed that she's hostile and she's rude. And the staff are wondering whether we need to change the meds or have an additional PRN. Next slide. So the question that I'd like you to think about first is, what would you do first? If you had your choice, would you prescribe trazodone? Would you prescribe risperidone? Would you ask for more information? Would you suggest the use of Posy-mits during the care? Or would you plan to see Mrs. M the next day? So think about that, what you would choose to do. Next slide. So the first step is to ask for more information. Often we try and make an assessment when we don't have enough information. And that can lead to going down a rabbit hole in the wrong direction. So the first thing, if I get a phone call like this, the first thing I want to establish are concerns around safety and to provide support for the staff. For the physicians in the audience this evening, it's helpful to remind ourselves how hard it is for a nursing colleague to phone us after hours, particularly. Our nursing colleagues are very aware that the intrusion into our personal time is difficult for us. And they, in my experience, having done this work for many years, people don't phone or ask for help unless they need it. And so just acknowledging that and establishing safety. Is everybody okay? Is anything that we need to do as a question of an emergency? Are there staff that have been injured and so on? And then also to try and establish in that question is during care, let's say it's not as much of an emergency, and to say, okay, during care, what are the safety concerns? When does Mrs. M try and bite or hit out? Have they noticed it's any particular time of day? Have they noticed there's been any change physically? For example, did she fall and maybe she's got soft tissue injury, or even worse, have there been any social changes to the milieu that she's in? Or have family members gone on holiday and they're not visiting? So those sorts of things we really want to get a bit of a deep dive about. Now, when you look after folks in long-term care, you get to know them well. And actually, that's your biggest strength, is that you know the patient. Because the better you know patients, the better you're actually able to determine which of these factors are important. And I want to talk a little bit about what I call the neuropsychiatric vitals. That is, and some of those are some objective instruments that we use, such as the DOS charting and the ABC charting, and then the nursing notes and conversations with nursing and other colleagues who are on the floors. Again, you know, as a physician, I come into a situation, I'm not there all the time. I don't know the patients as well. So discussions with nurses and other colleagues who know the patients well, including getting collateral from family, is absolutely vital. Next slide, please. I want to talk a little bit about DOS and ABC charting. And there's a little bit of a story around this, actually. In Victoria, we lost our DOS charting temporarily when the electronic health record was finally expanded to include medications and so on. And because the DOS chart is still a paper chart, it's not available online. Initially, it looked like we weren't going to have access to it, but we advocated, and Island Health saw the value of the DOS chart, which is heartwarming. It's because it's extremely helpful to us. So I'm going to go through those a little bit, but just to say for this particular situation, we've seen that there's been a long-standing problem with what was described as negative behaviors and hostility, and then aggression, particularly over the last month. So let's go to the next slide. And this is the updated DOS chart. There is a simpler one, which you may be using, which is not quite as frightening as this. This is the one that Island Health wants us to use. And it takes a little bit of getting used to. But in principle, the DOS chart, which is the Dementia Observation Chart or Dementia Observation System, was developed as part of the PIECES project, which some people may be familiar with. It is a diagnostic tool to try and determine whether there is a pattern to behavioral complications and to describe what the nature of those complications are. So it has a dual role. And ideally, the behavior is documented numerically because there's a numeric code every half an hour. And that enables us to see when the patient is sleeping. So it includes a sleep-wake chart. You don't have to do two. This is included in this. And when they're awake and calm, and then when they have challenging behaviors. It is incredibly helpful. We can then take it and look at it together with the MA and see whether medications are making a difference or whether the administration of some medications in fact appear to trigger the behavior. Nursing colleagues will observe whether perhaps the person was getting care at the time or whether they were having a visit or it was just after a visit. That enables us to really try and identify a pattern. So the DOS charting is to us in geriatric psychiatry what the pulse and blood pressure and so on, temperature are in other aspects of medicine. Next chart. No, sorry, next slide. I also use the ABC chart. And this is when we want to do a deep dive into a specific behavior. So the DOS chart is a quantitative chart. It actually tells us how many half-hour periods a person's unsettled or aggressive and so on. What the ABC chart does is it helps us to look at that specific behavior and to identify three main components. What was the antecedent before the behavior started? What was the nature of the behavior itself? What did the person actually do? For example, in resistance to care, if somebody sort of swats out, if they're largely nonverbal, or if they have very bad word finding difficulties and they're sort of pushing away and swatting out, that's telling us that they're trying to tell us no, which is very different from if they're actually trying to push and punch with a fist or trying to bite somebody. It tells us about the quality of the behavior, how dangerous it is. And then in addition to that, we look at the antecedents. So what was happening before? What were people trying to do? Were they trying to help the person change their clothing, doing pericare? What were people trying to do? And what was the behavior and what was the consequence of the behavior? So that will include, for example, often staff will say, we stepped out, gave the person space, reapproached in half an hour and care was successful, or we reapproached in half an hour and care was unsuccessful. We then gave a PRN and was that successful or not? So that gives us a lot of information about whether the consequences, our actions in terms of trying to respond to the behavior is helpful or not. And often, I must say, throughout my career, I have been surprised at how sometimes I inadvertently reinforce behavior without that being my intention at all. So are we giving the person more attention in a situation which they are lonely and they want attention, and so the more they may spit at us or vocalize, the more attention they get, and that's when we inadvertently reinforce and cause behavioral chains. We do that in our lives. We do that every day inadvertently. So it's helpful to be able to identify that under these circumstances. Next slide, please. So I'm not going to belabor statistics and lots of data, but I do think it's helpful to look at how common this challenge is that folks are facing. The most common behavioral complication of dementia is apathy. And I'm sure we've all encountered that with family members who say, he's just become lazy. He won't do anything. So apathy is a dysregulation of the prefrontal cortical pathways, which enable us to plan, sequence, and organize our behavior. This what I like to call the spark plug circuitry in the brain which enables us to actually initiate things. And that's often affected in many different types of dementia. The rest of the complications are still very, very common, and strikingly so. So in long-term care, 60% of patients with dementia at any given time will have a significant behavioral complication. And the median prevalence, so in other words, the most common number we see for neuropsychiatric symptoms or behavioral complications, is about 78% in long-term care now. And those numbers are going up in long-term care. As we all know, the ask of folks in long-term care is more and more to take folks who have behavioral complications, because unfortunately the prevalence is so common, and because of the prevalence of dementia in our community, with about a quarter of people around the age of 80 and half of those around 90 having dementia, and the baby boom and the consequent increase in number of elderly people, we're seeing this more and more. And so that's why you folks are being asked to do this very difficult work. Depression is common. Aggression is up to a quarter of patients, and psychosis can be up to about a third, as can agitation. Next slide, please. So I'm going to focus on resistance to care, and look at some of the factors which we can be thinking about if somebody is resisting care. And sometimes we forget about the basic things. I know today I was doing rounds in the hospital and I forgot to ask whether my patient was constipated, and then thought to myself, oh no, how silly can you be, when I got back to the office. So again, what are the causes of resistance to care involves us trying to figure out what the patient's experience is of something which is obvious to us. So we're the ones who have the relatively intact brains. We know what our intentions are. We know that they're benevolent. We know that our patient will probably feel a lot better after the care, but they don't know that. And they don't know that because, first of all, they have significant cognitive impairment. So their ability to interpret whatever information is coming into their brains is significantly reduced. And if we superimpose onto that other problems, then we start to get folks resisting care and acting in a physical manner to express their emotional distress or needs. So the first one is poor vision and hearing. And when I do a talk like this in person, I actually victimize the folks in the audience a little bit and get you to role play a few situations where you realize how difficult it is to communicate and to understand if someone has very poor vision and hearing. Audioverbal problems in terms of interpretation of what's being heard, or visual interpretation, is another layer that folks with cognitive difficulties are struggling with. Now, one of the things we do know is that visual interpretation is generally preserved better than audioverbal interpretation. So if a person has significant visual impairment, it really is a bit of a double whammy for them. And that's because, for example, when we're communicating with somebody, 70% of our communication is nonverbal. And so we can use that to reassure patients, to mirror their feelings, and to communicate simply but clearly with them. Equally, we need to be careful that we're not giving messages to the patient non-verbally that is leading them to become distressed or misinterpret. And for those of you who are familiar with Teepa Snow, I'm a huge Teepa Snow fan, and Teepa gives this lovely example of if a person approaches an elderly man, for example, and is trying to say to him, do you want to have a shower? But the person can't hear that, and so he has rah, 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 rah. And then the person approaching them is nodding, he will nod because that's the socially appropriate thing to do, even though he doesn't understand. And then the next step is, if you reach for his belt to undo the buckle in order to start helping him get changed, he becomes very aggressive or misinterprets it as a sexual gesture or something like that. And so that's how poor vision, when partnered with poor hearing and cognitive impairment, can lead to a real pickle in terms of communication. One of the second things that we often see in resistance to care is fear. And we don't know often what a person's life experience has been. It could just be that they're modest, but it could also be, unfortunately, that they've experienced trauma in their lives, physical trauma, sexual trauma, or it could simply just be that they don't understand what you're doing, and here you are trying to take their clothes off and it's cold. And then they become fearful of what your intentions might be. Because, of course, they've lived all their lives since they were very small, putting on their own clothes, taking them off, taking care of their personal hygiene and other basic ADLs. There could be a sense of shame attached to that, particularly if people are very modest. So we should be aware of that. The next thing is, of course, pain. And this is so difficult because for many of our patients with advanced dementia, if we ask them if they're in pain, we don't get an accurate answer. Part of it may be that they just have word finding difficulties and they're no longer able to appreciate what pain really means to them. But part of it may be that they live so much in the moment. And so you say, is it painful? And they can't feel any pain right now. But the moment they move or turn, or somebody moves or turns them, they do have pain. So there are a number of reasons why asking somebody if they have pain isn't always very accurate. And we do have the pain scales, such as the pain ad and so on, which can be helpful. But again, what can be extremely helpful is just knowing the patient. And often I've been in a long-term care situation and the staff have said, I think he's in pain because this isn't him. And there's just some kind of tell that I can sense. So again, listening to that is very important. Constipation is, as we know, a huge issue. I had no idea when I was training to become a geriatric psychiatrist that I would spend so much of my life discussing the Bristol chart. And so it's a huge problem, and because elderly people have changes in their gastrointestinal tract, they're on medications that make them constipated, they're not moving, their diet often is restricted in terms of fiber, and so constipation, if I'm always astonished, sometimes I'll see a patient who hasn't passed stool for 8 days, and I think to myself, imagine how uncomfortable that must be. And especially if you can't articulate that. So keeping a track of our patients' stools, bowel movements is very important. And of course, if somebody's very constipated, they may be leaking and you may be wanting to do personal care because they may have overflow diarrhea. But every time you touch them, they've got a distended, uncomfortable abdomen and they become distressed and combative. Okay, and of course, it could be all of these. Next slide. So these are the 3 parameters that I just wanted to emphasize. I often think, is it fear? Is it pain? Is it shame? Next slide. Now, this is the very disappointing slide of the evening. And people are always distressed when they see this. These are behaviors that do not respond to medication. We do not have effective medication for these behaviors. And I'm just going to chat about 1 or 2 of them to illustrate some things. Some aspects of these behaviors we can help with. For example, some sexualized behavior There are treatments that we can try pharmacologically, but sometimes people have been sexually inappropriate all their lives. And now that they have dementia and their prefrontal cortices are failing them, that becomes accentuated. And that kind of behavior is very difficult to treat medically. People often become very distressed when patients swear. And there's something which can be helpful here is if we understand what is happening in this a person's brain. Now, some people swear because they've always sworn and they're just carrying on with their premorbid behavior. But for many patients, they start to swear or use language which they would otherwise have found offensive all their lives. And it can be very distressing for families. And I find that families appreciate it when I explain to them that swearing, poetry, music we heard when we were young are stored differently in the brain. And that's because we lay down information in the brain contextually. And if there's a high emotive context, we tend to lay it down differently, and it stays that way. So swearing is one of those things. When we're small, our parents will respond to us with a high emotive context if we use an expletive in front of our grandparents, for example. And so we remember that. That's a bad word. We don't use that word. And so it's stored differently and we retain it more. If you think about the nursery rhymes that you knew when you were a child, I think about the poetry my dad used to read to me. I can just recite it off, all these decades later, because it's stored differently in the brain. So that can be helpful when trying to reassure families who find this very distressing. And so that's, again, why it's so important that we know our patients well, because if we know that this person wouldn't have spoken like that in the past, it's easier for us to care for them when they're saying awful things. One of the things that we find very challenging in care situation is repetitive vocalizations. And this responds very poorly to medication, calling out, shouting, and so on. We do have some situations where we can respond medically, and that is if a person is depressed or if they're very anxious, then we can treat it, or if they're responding to psychotic stimuli. But sometimes that repetitive vocalization or behavior is a consequence of boredom or separation anxiety, and then it's very difficult to address medically. When we are about 9 months old, we develop stranger anxiety. We develop a sense as babies that there are people that are different from us, and we become a little apprehensive. We also develop a sense of what we call object constancy, which we develop as toddlers. A small baby, you put them in the high chair and they'll drop something on the floor and they'll say, oh, gone. And then you look down and it's a big joke and you pick it up and so on. And that's because they don't have a sense of object constancy. They don't have the sense that this thing still exists, even if I can't see it. And we do see this in some of our demented patients, that they lose a sense of object constancy. So if their loved ones walk out of the room, their loved ones have gone. And so they become extremely distressed. So we and then they may respond. So sometimes understanding the context in which somebody is, calling out. Often they're wanting somebody to come in so that they know they're reassured. They may be afraid and so on. So those are just some examples. And I'm afraid there's nothing we've got that can change a person's personality. If they've been a somewhat challenging personality all their lives, unless they change significantly just as part of the dementing process, unfortunately, we don't have any medication for that. And that can be a very challenging situation where you have somebody who's social cognition has never been very robust, and now they have a major neurocognitive disorder superimposed on that. Next slide, please. So why do people feel afraid? They feel afraid for all the same reasons that you and I might feel afraid, but there's some additional reasons that are helpful to think about. Poor information processing, the sensory impairment I spoke about, poor visuospatial abilities. So sometimes things just suddenly appear to come out of nowhere because they've got poor peripheral vision, or they may have macular degeneration, and so they may have poor visual acuity as well as poor visuospatial ability. So they don't always know where they or other people are in space. So moving them can be very disconcerting. I'm sure all of us have experience looking after folks who have a transfer apraxia. So we try and transfer somebody, say, from their wheelchair to their bed. And in that process of trying to transfer them, we find that they're not able to put their arms and legs in a sensible position. And that's because they have a transfer apraxia. Their brain is not able to communicate with their body in terms of where their arms and legs are in space, which can be a big challenge. Postural hypotension is a real challenge for those who have Parkinson's, people on medications, including the medications we use, which I'm going to talk a little bit about, the antipsychotic medications, which can drop the blood pressure. So if we look at, oops, we can go on to the next one, that's fine. So if we look at pain and discomfort, again, there are many reasons that a person may have pain. Osteoarthritis, cancer, GERD. They may be dyspneic and they may develop a sense of air hunger, which is very unpleasant. It's not pain per se, but it's discomfort. And then I spoke about constipation. And then there are other things like atrophic vaginitis, a UTI. They may have stubbed their toe and nobody may have realized, etc. Next slide. And then shame. Just about being nude, about being exposed. If any of you have been in hospital as a patient, you'll know how disconcerting it is to feel so helpless and dependent on others. And this is also where a trauma-informed approach can be so important. And we need to understand as much as we can of our patient's history. Next slide. So to go back to the management now, this first step I chatted about was to gather information. The second is those neuropsychiatric vitals, or the geriatric basics, in terms of trying to identify through documentation in the new electronic record in the hospital. The annotations and the other forms of communication from the nurses are so helpful. Nursing notes, talking to each other, different team members and so on. And then the ABC charting or DOS charting if we need to. And that enables us to then identify and address the possible causes. Next slide. Okay. So which one would you address first? Think about this. Would you address the constipation, severe pain, modesty, fear? Which ones would you think about? And I deliberately talk about this because this is so different to medication management. In medication management, we try and do one thing at a time. But in this situation, what we're trying to do is address all the factors that may be at play that shouldn't be operating. So it doesn't matter whether it's causative or not. We should address constipation. We should address pain appropriately. We should treat people respectfully with respect to modesty and so on. And so, in my opinion, we should address all of those. Next slide, please. And so this is really about talking about medication, how different that is. So with medication, if we change 2 or 3 things, let's say we just change 2 things, and the person gets better, we won't know which one of those things caused it. Or if they get worse, we won't know which one of those 2 things caused it. So I always say, let's be careful that we don't land up a creek without a paddle. Likewise, we can use that principle with some of our behavior strategies. For example, if we're thinking that a weighted blanket might be helpful for somebody, and we're thinking that maybe they want a different pillow, we may want to do those 2 things separately. Because again, if they become increasingly agitated, it could be because of either one of those 2. And in that situation, the difference with the other factors I spoke about is that all those other factors should be addressed by us, whereas in the second example, we're starting to use strategic thinking and be creative in terms of our care planning. Now, the exception in medical situation is in an emergency situation. And then, of course, we often have to do more than one thing at a time. Next slide, please. So I'm given here some examples of some of the strategies that we can be using. For constipation, the literature indicates, and certainly our experience in our geriatric teams, is that PEG is the best intervention. We don't use Metamucil in our seniors because they are almost inevitably a bit dehydrated, and then it can be really awful for them. And things like Senocot has lots of complications down the line, but also can cause a lot of cramping. PEG is helpful because you don't have to drink a lot of fluid with it. It can cause a little bit of cramping, and of course we have to get the dose correct to find that good balance for the patient, but generally quite well tolerated. Now, one of the challenges with pain is how underdiagnosed and undertreated it is. In fact, if you look at the studies, it's a bit shocking. And if you think about how awful it would be to be in severe pain day after day and not have that attended to, it's a cause of great suffering. If a person is already on an opioid for, let's just say they've had a recent hip fracture, then we have to be careful that the opioid isn't itself causing difficulty. And that can be a bit of a challenge to see, are we undertreating the pain or are we over-sedating the person? In terms of the opioids, we like to use the buprenorphine patch. It's better tolerated, and it's certainly indicated ahead of some of the other harsher opioid strategies. For many of our patients, they have impaired renal function, and then it's difficult to give them a non-steroidal safely. But just to start with regular acetaminophen, to give that 3 or 4 times a day in a good dose, because with pain, we don't want to play catch up. We want to stay ahead of pain. It is much more difficult to play catch up. And then don't forget that our folks are immobile. And, you know, as the physios always tell us, motion is lotion. And that if we move, it alleviates our pain and certainly helps us in terms of soft tissues, our muscles, and so on. And so gentle movement and using a warm blanket it can be helpful as well. It doesn't always have to be a pharmacological strategy. And remembering to help our patients change position, because we change position all the time, even though we may be sitting in a chair and think we're relatively stationary. We change position to a small degree all the time in order to be more comfortable. And because of mobility problems, such as, say, Parkinson's disease or stroke or advanced frailty, as well as cognitive reasons, again, the brain not telling the body to move when it should, our patients can stay in one position for a long time, and that can lead to pain. And we know, of course, it can lead to other difficulties such as skin breakdown. With modesty, there are a few tips that we found helpful. Handing the person a cloth If they've always used a cloth to clean themselves, face cloth and so on, handing them that cloth and helping them maybe to wipe their face or do something which is comfortable for themselves, even holding it in their hand, that will help them associate the care with something positive and less frightening. Modesty aprons can be helpful. And then to be careful how we speak to patients, which of course we should be all the time. But if somebody is really struggling, then working out, and it's largely through trial and error, what is best for reassuring this person? Is it best if one person speaks to them and stays at the head of the bed and is the sort of buddy while the other person does care if we need two people? Be careful not to chatter with each other about anything that's going on in the world or something that's not relevant to the person. Only speak to the person or to each other if you need to communicate something for the care. One of the things we've used at Couch and Lodge at our tertiary unit there are Cheetos, the little puffy, chippy things. We've put them in cups, just the regular water cups, and given it to patients to eat during care or when we're trying to do something where patients may feel uncomfortable. You can't really choke on them because they disintegrate. And we find that can be very helpful. You don't have to, worry about supervising them. And if they throw it at you, it's just Cheetos. Okay, next slide, please. So this is what happens with the generation of a fear cycle. That patients form an association with the care and a negative outcome. Now, people can do this for a long time in dementia. They may not be able to learn information intentionally or declaratively. In other words, if you explain to them, we're going to give you care now and you don't have to worry and so on and so forth, they may not be able to learn that, but they can form habits. And the basis of a habit is forming an association, which then becomes predictive. So they associate care with a negative outcome. And this may be something which, is from their childhood because of cognitive difficulties, or it may be something that happened when they were in hospital before they came to you, or who knows. And then what happens is they anticipate harm. They develop this anticipatory anxiety. And when that happens and we can't get out of the situation, we will all exhibit fight, flight, or freeze. We will try and defend ourselves. And if we're not able to say, I don't want you to do that, it makes me very uncomfortable, what do we do? And so this is when we often see our patients then react physically as an expression of their distress. So one of the things that is extremely helpful is to facilitate positive associations with care. The challenge is that in a very busy long-term care environment or hospital environment, this is difficult to do. It's simple, but difficult, a bit like dieting. In the sense that we need to give them non-care contact. And that means popping in to see the person, giving them a treat that they like, some high reward item that their family's told you, or, they love ice cream or whatever it is, and then just popping out. So they begin to associate nurses or other care staff with a positive interaction. Now, that is a big ask in a busy long-term care or hospital situation where you've got a whole lot of competing demands. But when there's a lot of physical danger in giving care to somebody and they're very distressed, it is certainly worth doing in those specific instances. We should try and do it as much as possible, but of course there are those limitations. Next slide, please. So understanding aggression, people become aggressive for all sorts of reasons. And, remember, we all behave, and we can all behave badly. I would assert that we all have at times. I know I have at times. And so unpacking that is where, everybody can have a bad day, but we don't generally put other people or ourselves at risk when we're having a bad day. So one of the first things that can be helpful to understand is the concept of theory of mind. This is a concept which was initially described in the autism spectrum literature. And that is that we generally learn as children that other people are people. We learn empathy. We learn the ability to put ourselves in other people's situation and try and look at things through other people's eyes. We will have an argument with our friends when we're small children, and our parents will say, we'll try and see it from their point of view. And we continue to do this throughout our lives. Sometimes it's difficult to see things from other people's point of view, but we try to do it. So what happens when folks develop dementia is they often lose this ability. So Teepa Snow would say, folks with dementia will say, I want it when I want it, when I want it now. In other words, they have an unmet need, they want that need addressed, and they don't appreciate that you may be busy or that you may need to do something first to help them before you can meet that need. They may not be able to hold your explanation in mind. So they don't appreciate the impact that their behavior is having on you. They lose that ability to some extent. Now, the folks where we see this loss early on, and which can be so devastating, is in frontotemporal lobe degeneration. In those illnesses where the prefrontal cortex is predominantly involved, and it can be devastating for family members because people can say very hurtful things, and they have no knowledge that they're hurtful. So another thing that can help us understand this a bit is the idea of retrogenesis. So that's the idea that there is some regression of ability that happens during dementia to some extent. There's the loss of ability that was gained when we were growing up. For example, we learn to be continent and we can lose that ability. Equally, we learn social skills and we learn that if we hit out at somebody, it could hurt them, and we may lose that ability. So that's tied in with theory of mind. Then, of course, there's the fight, flight, or freeze exercise, which can, the fight, flight, or freeze phenomenon, which can be a big factor. And when I do this talk in person, I do an exercise. That's why I put the little word exercise to remind me to tell you about it. And this was an exercise that I learned when I did a course with Teepa Snow, and you can do this with each other, but you must get permission first, is where you ask someone to sit with their eyes closed, and then you poke them just next to their ribs and see what their response is. Do they withdraw? Do they freeze? Or do they hit out? I'm afraid to say I hit out. I went like this, bang, you mean I went, hey, and went like this. So that may be a natural response. Again, you must get permission and explain that, what you're going to do. But it can be an interesting exercise to realize that actually we all have our kind of default, and that our default may change in different situations. If we feel threatened physically, we may hit out. If somebody is verbally aggressive to us, we may withdraw. And yes, and then the role with aggression is always to use non-pharmacological strategies, but there is a role for pharmacology in aggression. Next slide. So with this particular patient, constipation, she was day 8, adding a buprenorphine patch and addressing the constipation simultaneously. Never add a buprenorphine patch and don't address the constipation was very helpful, and care was much improved. But with this particular patient, there was still a degree of hostility. She didn't want to sit and eat. She was a bit intrusive after about 4 in the afternoon. And she started to ruminate and talk about the fact that she had no clothes and that part of her body was rotting away. Next slide, please. And these are the medications she's on. So not very much. For most of our patients, they're often on more. Amlodipine for her blood pressure, some Advair and PRN, Ventolin for a little bit of COPD, Trazodone for sleep induction, and then the regular Tylenol. Next slide, please. So medications are excluded. I showed you that list of medications just to show you that I don't think that's material in what's going on. But to again think about it, I saw someone in the chat, a comment come up about akathisia, so I was delighted to see that because I'm going to chat a little bit about that. So what could be going on here? Delirium, she's sundowning, she depressed. Is there an element of akathisia? Next slide, please. So again, we get collateral. So if for me, that would mean talking to my nursing colleagues and physio and OT and social work, whoever's involved with a person's care, family, and so on, DOS charting, and all those principles that I spoke about. Some of the things which are really helpful is, who was this person when they were in their prime? What kind of home did they live in? What were they proud of? What are their likes and dislikes? Some people don't like heat. They feel they like to run cold. Other people, and often in the elderly, tend to get cold easily. Do they like particular kinds of clothes? Maybe they dislike a specific color. All those sorts of things. Were they introvert or extrovert? I really like exploring this, because if you're an extrovert, that really means is, as an extrovert, it means that we kind of refill our cups, recharge our batteries in company with others, as opposed to an introvert where we need some solitude or withdraw from that. Now, if you're an introvert who's always led a fairly quiet life, you have a small group of friends, and suddenly you move into long-term care, that can be a bit, overwhelming. And equally, if you're an extrovert and suddenly all your family and friends are not visiting, and you've become immobile because you fractured your hip and you're stuck in your room, that can become very distressing. So knowing who the person is can be helpful. We use a My Story, which is just a narrative of who the person is, a whole lot of questions, which my colleagues at Couch and Lodge will ask family, and we fill that in so that all the staff have access to it. There are a number of others tools that you can use, but really just to try and document, who is this person in the world. Next slide, please. So what we found out about Mrs. M is that she's a retired librarian. She's an introvert. She was diagnosed with Alzheimer's disease about 8 years ago. She's always been very gentle and kind, and her family were her life. She had a very good sense of humor. And when she was first diagnosed with Alzheimer's disease, she had insight into the fact that there was something wrong with her, and she developed quite a significant depression as part of that, coming to terms with that awful diagnosis. What happened in this particular patient, this happened during COVID, and she had had no visitors for a year because of COVID. She was very isolated. She was very depressed. Her family lived in the US, and we used to try and use FaceTime and other things for her but that had been a big impact on her. Next slide, please. So in her situation, we made the diagnosis of depression. It's very common in the elderly, particularly in long-term care. And COVID-related isolation has had a profound impact on patients. And it continues today. I'm sure all of us know that there are many programs which stopped during COVID that have not been restarted, and our patients remain isolated as a result. Loneliness and isolation is such a big problem with seniors now that some of you may be aware that there are 1 or 2 countries in Europe now that have ministries for the prevention of loneliness in elderly people, particularly in people with disabilities, because of the massive impact on morbidity and mortality. So for folks who have dementia, the primary intervention we always want to use is a non-pharmacological strategy, using technology, meaningful activities, the use of transitional objects. So a transitional object, if you think of a child who has a favorite teddy bear, and they hold on to that teddy bear when they're feeling distressed, then that can be very comforting for them. That's a transitional object. And so having something which is meaningful for this person, that is soothing, that they can hold on to, can be very helpful. At Couch and Lodge, we use transitional objects and soothing objects for meaningful engagement. For example, robotic dogs, cats. We have realistic looking babies. And we had a delightful situation that arose where we had 2 or 3 of our residents there, and this is a tertiary facility, so folks have got significant behavioral complications. And 2 or 3 of them were having babies and in their care. So they had these little babies and they would look after the babies, and we made we had little blankets and places where they would sleep, which were their cots. But if you're 90 and you're looking after a baby, it gets pretty tiring. And so 2 of our patients complained and said, this is a real deal, being a mum. And so we created a little nursery, and they could put the babies down in the nursery, and the babies could have a nap, and everything was good. And our residents could then have a break from their babies. A warning about robotic dogs and cats is that sometimes the noise that they make, the purring or the meowing or the barking or whatever it may be, can be a little annoying for staff or for other residents. And then it's natural that we want to switch them off. Warn the patient that the dog or cat is going to go to sleep, because otherwise they may think they've died. And we have had a few disasters as a result of that. So in this situation, this patient was so depressed that she did need an antidepressant. And so we started her on an SSRI, and she made a very good recovery. Next slide, please. So before starting an SSRI, I'm going to talk a little bit about medications now. Before starting an SSRI, what do we need to do? We need to do an ECG to make sure that the QT interval is not too broad. Any concerns about impaired renal function or prolongation of the QT, if we're going to give an SSRI, sertraline is your friend. Sertraline is the drug to use. Otherwise, we tend to use either escitalopram or citalopram. And we do not like to use fluoxetine and paroxetine. They both have a number of challenges in the elderly. Checking the sodium is a very good idea to get a baseline. Many elderly people, sodiums tend to run a little low, but SSRIs do have an increased risk of SIADH and dropping the sodium. And then we want really to do all, number 6, all of these before we prescribe an SSRI. Another good question to ask if you have collateral available is whether anybody else in the family has had depression and whether they have responded well to a particular drug, because we know increasingly now with antidepressants, pharmacogenetics or genomics can be a very helpful tool. Next slide, please. So these are the factors that I suggested, and we can just proceed to the next slide. Sorry, don't know, I was being overly thorough. So Mrs. M improves, and a few interesting things the staff noted. First of all, that her room was very close to the nursing station. It was too busy for an introvert. For an extrovert, it can be a complete delight. You know, you keep your eye on everything. But they moved her to a quieter area, which she really enjoyed. And then she enjoyed having that one-to-one low-key involvement, and the volunteers, when they came back into the unit, did that. And so there was resolution of her symptoms. Next slide, please. So what do antipsychotics help for? Our patients, many of them are on antipsychotics, and what do they help with? Well, in the situation where a person is delirious, they can be very helpful for agitation, psychosis, and aggression. And that's a specific indication. In psychotic symptoms with a pre-existing disorder, a pre-existing psychotic disorder or mood disorder with psychotic features, there they have a primary role as well. In people who have behavioral and psychological complications of dementia, in psychomotor agitation and aggression, they can be helpful. And of course, if somebody is psychotic, if somebody is paranoid or has delusions, hallucinations, and so on, then they are helpful. But they are not brilliant in folks with dementia. They can be miraculous in people who have a delirium or people who have a depression with psychotic features. In our Mrs. M, that preoccupation that parts of her body may be rotting is quite a common symptom we see, that kind of nihilism we see in elderly people. And certainly if that had worsened, I would have started an antipsychotic, but it was just fleeting and people could reassure her. And she responded so well with the antidepressant, we didn't need to, but we did discuss it. And the family asked us to hold back, and it was a success. Side effects of these drugs are substantial. And one of the dangers we get into is that somebody's aggressive. We start some olanzapine, for example, they don't respond, so we increase the olanzapine, they don't respond, so we increase the olanzapine some more. And then we add something on top of that. And that's a very tricky situation, which we really want to try and avoid. Next slide, please. So the familiar mantra is that we start low, we go slow, and we consult the geriatric dosing guidelines carefully for dosing. And I do this all the time, and we have up-to-date on our computers now in Island Health, which is super helpful. Otherwise, I use an app on my phone if I'm not sure. And then the clinical pharmacists are so helpful if we're worried about lots of drug interactions. And if I'm not familiar with the medications patients are on, I'll look up the drug interactions, and I can also ask a clinical pharmacist's help. When we're trying to decide what medications a patient on is, remember over-the-counter medications, even if they're in care, you've had situations where families or friends bring in all sorts of things which have interactions. One of the most famous is St. John's wort that people may bring in if they feel that people are a bit down in the dumps, and those have, St. John's wort actually can have some catastrophic side effects. a regular medication review is very, very helpful. We all get medication blindness when we look after patients for long periods, where we don't actually see, when we look at the MAR, all the different medications they're on. So prompting us to do a medication review is very, very helpful. Next slide. I wanted to have lots of time for questions, so I haven't gone into the issues around akathisia and some of the other side effects, but I'll be delighted to talk about that if people want me to. Just a few concluding remarks from my perspective, and that is that people matter. Our patients, our clients matter. And that they are just as fully human as we are, even though they have a failing brain. But staff and families looking after our clients and patients also matter. And it's important for us who are involved in this care to respect that and to support those folks who are doing this difficult work. What makes the work so much fun is that you become a detective. You know, you want to know, is it a person's premorbid personality at play? Is it their physical ailment? Is it some illness they have? Is it medication? Do they have a primary psychiatric illness? Is it the environment? Is it the fact that the man next door yells out every night and they're not getting a good sleep? And we can make a huge difference to our patients' and clients' lives. And so I know those of you who know me know that I am absolutely passionate about this work, and I think it's an incredible privilege to do it. And just to remind us of that every day when we're filling in more paperwork and are stuck to the computer. So I'm delighted to take any questions. I did see one pop up. I'm sorry I couldn't keep all of them up, but I did see one pop up. Somebody was asking, what do you do when you can't get collateral? And I if I may just address that one first and then open it up. That's such a good question, because sometimes we don't have it. And in that situation, it's building a relationship with that person. So what I do is I ask different shifts. Can we, I'll speak to the CNL, the DOC, whoever is the person who knows a person best, and try and build up a picture of who that person is. And over time, as that person, say, comes into long-term care, you'll get to know them. And a lot of it is trial and error, and just thinking, I wonder what their favorite food is. And then giving it a try. And when you discover that, then you share that success on the care plan. I really love care plans who share successes and not just focused on disability, focusing on ability, focusing on what really helps the person. And then you say, wow, I found that this was helpful. I know at Couch and Lodge, we've had observations from the staff who deliver the food, the staff who do the laundry, all different members of the teams that have been invaluable. So just building that together and building that data. So I'm not quite sure how to do the questions.
If I can jump in, Jane, it's Ralph Jones from Chilliwack. Sorry, because I'm in the car and I don't seem to have a lot of the controls on my Zoom. Fantastic talk. I love your approach. That's mine exactly after 26 years in long-term care. And it is, it's a fascinating intellectual exercise as well as helping people. It's where we're using our shoulder-top computer. And I loved your emphasis on the social history, which I iterate over and over again. And just to give an example, we've been batting this around our long-term care discussion groups. One of my colleagues had a resident with frontal temporal dementia, very, very aggressive, and particularly at meal times. But the social history, they knew he'd been on the Canadian junior ski team. So they set up a GoPro screen and just showed somebody skiing, the same clip over and over again. And he watched it fascinated for hours and enjoyed his meal. So the social history is so important.
Yeah, that's a fantastic example. Isn't that wonderful? Finding out who this person is and then just trying to see, because watching that will soothe him. It'll be incredibly soothing for him in an otherwise bewildering world. And also with frontotemporal, he probably was trying to nick other people's food as well, which can be such a challenge during meal times. So just a wonderful example.
Are
Other
you able to
questions?
see the other questions in the chat, Dr. Saunders?
I can't see the chat for some obscure reason.
Okay, would you like me to read a couple of them
Yes,
out to you?
just choose away.
Sure. Let's see. From Karina, she says, we host residents from the community and don't see them for more than 36 days a year. Our knowledge of our residents is constantly changing as they change. Is there anything extra we should be doing to assure we are doing our best to serve those patients? Thank you.
I think the first most important thing you're doing is asking that question. Because if we ask the question, how can we best serve these folks, we tend to approach them with curiosity. And I think that that's where the magic is. So finding out as much about a person before you see them, having any history from family, primary care providers, anything can be helpful. And then just trying to meet them where they are and go from there. But that is, you know, if you don't see them for long periods and then suddenly you're seeing them, that can be a challenge. And trying to get as much information from the people who've been with them in the interim is where I would start.
Okay, next question is from Brian Say. Thank you for the talk. Thoughts on, and I'm not sure I'll pronounce this correctly, duloxetine,
Yes.
duloxetine in the context of fluoxetine and paroxetine not being encouraged.
Right. So duloxetine is an SNRI. It's a cousin of venlafaxine. It's an antidepressant, anti-anxiety, and it also has some value in pain. And duloxetine can be very helpful, particularly in folks who have neuropathic pain or pain syndromes. The only challenge that I find with duloxetine is because of how it's available to us. It's not easy to titrate the dose with any degree of finesse. We start at 30, then 60, then 90. But it is a medication that we would try under those kinds of contexts. It's generally quite well tolerated. Constipation can be a challenge, increased sweating, headache, all the usual problems like with venlafaxine. There is a more ease of finesse in terms of titrating the dosing, but perhaps not as effective for pain. And then in the higher doses, we have to watch the blood pressure. But otherwise, duloxetine and venlafaxine have very similar side effect profiles. We don't like fluoxetine. It can be very agitating. It's got an extremely long half-life. The active metabolite of fluoxetine is norfluoxetine, and it has a half-life of 10 days. And so once you give it to a patient, it can be problematic for a long period of time. Paroxetine side effect profile and some of the drug interactions are also problematic. These are guidelines. There are exceptions, of course, always, as there always are in medicine.
Divya wants to know which antipsychotic do you tend to use?
So I don't know when it happened, but at some stage in British Columbia, there must have been some very good drug reps promoting quetiapine, because people love using quetiapine. In fact, the studies show that for behavioral complications, for aggression and so on, it's not as effective as some of the other medications. So there are some very important exceptions to that. If a person has Parkinson's disease or Lewy body disease, the higher potency antipsychotics can be very dangerous. So as a general rule, we use quetiapine first line. There is a new agent available for psychosis in Parkinson's disease that isn't readily available in Canada yet. We're waiting for it. And then the next step is often to be very tentative and try and use some olanzapine, or even to proceed to clozapine. And those are really difficult things I wouldn't do alone. I certainly think a geropsych would be helpful under those circumstances. In our tertiary unit, we have for some folks on predominantly we would start with quetiapine, and then we would go to clozapine if we were worried. And some folks have done extremely well on tiny doses of clozapine, but that's a technical and tricky thing to do. Lots of informed consent and conversations and so on. If a person has a delirium and they're in hospital and they're very aggressive, I tend to use Risperdal as first line, as long as the person doesn't have severe renal impairment. Quetiapine is actually safer in that circumstance. And bearing in mind that all these drugs can drop the blood pressure. One of the side effects that Risperdal has that people often don't realize is that it can cause edema. Pedal edema, which can be quite nasty, and then people start giving folks Lasix and things. So it's something to think about and watch out for. But it is a high potency drug. So Risperdal, aripiprazole, and so on, those are what we call high potency drugs. And so that tends to have the extrapyramidal side effects and has an increased propensity to cause akathisia. Akathisia has a triad of symptoms. It's the subjective sense of a compulsion to move. The objective, often need to move, is observed, that people are tapping their feet all the time, or if they are mobile, they're pacing. Not always seen in the elderly, but the third component is often missed, and that is they have often an intense sense of dysphoria. So if we give somebody an antipsychotic and then they start to appear to have, to get worse and worse and worse, we have to be careful if we're making them more agitated. I use olanzapine, just to kind of round off the question, I use olanzapine and aripiprazole in circumstances. I try to follow a kind of considered approach where I'll try one medication for the target. Let's say it's for psychosis or aggression, and then I will balance efficacy with tolerability. And if I don't achieve adequate efficacy and I have poor tolerability that interferes, I'll stop and then consider other options. Olanzapine can be helpful. It tends to stimulate appetite. It is more sedating. It's what we call a lower potency drug. And so we have to be careful about sedation, but sometimes it can be helpful as well.
Great. Dr. Ola has a question as well. Thank you for an excellent presentation, Dr. Saunders. What are your thoughts on using stool consistency to guide the choice of medication for constipation? For example, would it be appropriate to use psyllium or bran for constipation with soft stools, PEG or enemas for constipation with hard stools, and or senicides for constipation with normal stools?
Right. I'm not a gastroenterologist. But my experience is it depends where the person is, where they're living, and it depends on what their diet is and how much they drink, their hydration, and how mobile they are. In a busy long-term care setting, I think having a stool protocol is very helpful. And so then there's less finesse. If they're at home and they are mobile and they go for a walk every day and family members can ensure their hydration and their stools are relatively soft, then using psyllium is fine. The problem with psyllium is that if a person gets a bit dehydrated, the stool very quickly turns to concrete, which is very unpleasant. So I tend to use PEG as my first line for simplicity. But, you know, the gastroenterologists may have a more refined approach. But that's the approach I use. And I know my geriatric medicine colleagues who I work with every day, that's the approach they tend to use. A fairly simple approach.
Regine Joy is asking, we have this patient, I think that has a dependent behavior and is depressed. One of the counselors, I think, suggested that cannabis and psilocybin can help depression. Is this true?
First of all, cannabis, there is not good evidence for cannabis being helpful for depression. There is good evidence that high potency cannabis and THC can be psychotogenic, can induce psychosis. And so we have to be careful, and it can make people very anxious. So that's the THC. There is some evidence for the use of CBD cannabis in anxieties, in pain syndromes, in nausea, in folks who have cancer, and some people use it in insomnia. The evidence in the elderly is not great. We're still, you know, cannabis has only recently been legalized, decriminalized, and so there are very few studies that are robust and that have been replicated. I have occasionally tried CBD in folks who are calling out and are very distressed. Particularly when families have been interested in that. And I would say that I've had one or two successes and quite a few folks just not tolerating it, becoming too sedated. So again, you know, if we think about the brains of folks who have dementia, they are fragile. And so that's different to the general population. Psilocybin is the current hot topic of conversation in psychiatry, particularly in the treatment of mood disorders. The initial work that came out was around post-traumatic stress disorder in veterans, where it's been shown to be of quite significant benefit. There are some studies, relatively small numbers, showing its efficacy in depression. It's seen particularly in folks who have resistant depression and who have major depression as opposed to persistent depressed mood. So somebody who has, or we used to call that dysthymia, somebody who's always been pessimistic and prone to being a bit down in the dumps, they don't seem to respond as well. Again, they are still figuring out the dose. They're using these micro doses. In order to go on this medication, to my knowledge, you have to go off all the other antidepressants that you've been on and other psychotropics. I've had a few patients who have had catastrophic relapses, and I've had other patients who say that it's been extremely helpful. But I don't think they're trying it in folks with dementia. I think they're trying to build up the literature in people who are physically robust and cognitively intact at the moment. I saw a question about memantine and donepezil and when to stop it. So that's a very good question. Generally speaking, once a person has advanced disease, it's worth thinking about stopping these agents. Most commonly, people will be on donepezil just because of its availability and the literature, or another cholinesterase inhibitor. And in advanced disease, if a person becomes agitated, and let's say their MOCA is below 10, as a kind of broad example, they're in long-term care, they're becoming agitated, they're not delirious, and they're on donepezil, I very gently decrease the dose. I'll taper it slowly to see if it isn't in fact the donepezil, because it can worsen agitation later on. The bottom line is, when these medications are no longer helpful, just like any medication, we should think about stopping them. And when people have very advanced disease, we should think about what are we trying to achieve by continuing them, and then slowly decrease the dose and see if it makes any difference to that person's quality of life. And that would be my sort of principle. I think in terms of the province, they don't want to dispense it if the MOCA is less than 10, but I think we should do it on a patient-by-patient basis and see what people need.
There's
Should we
another
take-
question here from Maria.
Should we
She
take
says-
2 more, Gillian?
Sure. Oh, well, there's only 3 left.
Okay, well, let's do them. Let's do them.
Okay. All right. So Maria asks, what is the approximate timeline to see if medication is effective or not?
Oh, really good question. And it depends on what you're trying to do. So if somebody's psychotic, it will take a while. Often we don't change the dose unless there are problems. We won't change the dose for several days. And that is because of the way the brain works. It's not like giving Tylenol and waiting for, just a few hours for the temperature to come down, or an antibiotic for example. It's that these medications change the neurotransmitters, usually at a receptor level, the availability of neurotransmitters, which then have secondary effects. And then it's like a domino effect, and it goes all the way down cascades to things like brain-derived neurotrophic factor and various other things in the brain. And this takes time. With depression, for elderly folks, it can take longer than for younger people. So younger people, we usually say that by about 4 weeks, people should start responding to antidepressant if it's at an adequate dose. In the elderly, it can often be up to 8 weeks. So it's often a question of patience. If it's a safety issue, I increase the medication more rapidly, or I may add an augmentation more rapidly. With depression, we often see the vegetative symptoms responding first. In other words, their appetite improves, their sleep improves, they appear to concentrate better, less rumination, and then the subjective sense of mood is often later. So the other thing is that if somebody has psychotic symptoms and they have dementia, we don't necessarily wait for them to have complete resolution of those symptoms. That's often difficult to achieve. My first goal is to alleviate suffering, to make sure that they're not causing distress to others, or they're not distressed. But if they continue to believe that the neighbor down the road, is actually a member of the family at Downton Abbey, and it's not distressing for them, that's not a goal pharmacologically. But if they believe that they are being stalked by that person who is coming to kill them, then that is a goal. Hope that's helpful. We got 2 more, Gillian.
Yeah, so Christine would like to know, could you please talk about the interaction between sertraline and
Sertraline, yes.
olanzapine?
sertraline and
Olanzapine.
olanzapine. Okay. So generally speaking, if you look up their interactions, it depends on what other medications they're on as well, because these medications are both affecting the cytochrome P450 system, which is like a system of locks, like locks that boats go through in the liver, but they're also substrates, so they're also affected by it. Generally speaking, these two medications are well tolerated together. That's a kind of bottom line. And sertraline is a great drug to use if somebody's got cardiac problems or significant renal impairment, which is great. We can use it even in folks on dialysis.
Great. And
Okay.
final question.
Last one.
How can we mentally or socially support a resident who has been recently diagnosed with Lewy body disease? Any recommendation to support the resident and family as they go through the journey?
Wow. So Lewy body disease is one of those brutes. All dementia is awful, but Lewy body disease can really be brutal. If the resident has insight, then my focus would be on supporting the resident, providing them with my reassurance that everybody's journey is different and that they will not be alone, that we will walk beside them. And have more frequent visits with that person. And I would really try and meet them where they are. Not assume they have questions that I would have, but to see what their fears may be. Sometimes patients' fears surprise us. They are not what we would expect. So I don't presume that. But I would, again, get to know the person. What are their fears? How capable are they at the moment with respect to information? Get collateral from the family. Is this a kind of situation where they would want to have more information? Remembering that if somebody has cognitive impairment, they may easily become overstimulated and overwhelmed by too much information. So just meeting them where they are and seeing. Family, I, if possible, would try and meet with the family separately so that they could ask very frank questions and we could have a fulsome conversation, and they wouldn't be fearful of protecting their loved one's feelings and then not getting the information they need. And that separation in terms of those two interviews, usually I'll do something like a colleague of mine might take the patient to do a MOCA test or a get up and go test or something simple like that. And I will, of course, get permission and say, do you mind if I chat to your family members while you're away? I'm not necessarily specific about all the questions I'm going to ask the person, but in general terms, I'll get permission and then have that conversation. Sometimes I find that family members are really on different pages with respect to their understanding of the illness and their expectations. And then having a family meeting with all the family members together to get them all on the same page, give them an opportunity to ask questions in front of each other. That can be very helpful. And I call it front loading. I don't know if it has another word, but I'll often say to colleagues, let's really have a front loading conversation where we provide a lot of support up front for families and get the families on the same page so that the primary caregivers, often the spouse, is well supported by the family members. And then if a person is in hospital, whenever possible, or in long-term care, whenever possible, I'll chat to the staff and see what their understanding of Lewy body disease is. and explain to them, because some of the most mystifying things can happen in Lewy body disease. For example, it fluctuates. People can look as if they're about to lose consciousness, and the next minute they're agitated, and it really, fluctuation is one of the core concepts in the illness. Then they have these visual hallucinations, they have REM behavior sleep disorder often, and so it can be bewildering and overwhelming. Hope that helps. I think we're done. Are we done?
I think so. Thank you very much for your
Pleasure.
time, Dr. Saunders. We really appreciate it. I'm sure I speak for everyone when I say that. And yeah, thank you again for joining us, everyone.
Thank you, everybody. Have a good evening. Bye-bye.
Bye.